Hari Om. Panchajanya, the divine conch of Bhagwan Sri Krishna, which was blown during Kurukshetra, indicating the start of the Dharma Yuddha that followed. There all the efforts were done for the establishment of Dharma. Dharma was kept over personal relations and motives. Keeping the same motive in mind, our organization will work towards establishing the importance and necessity of following and imbibing Bharatiya culture, accepting our roots, and making people realize the true essence of Ayurveda, not only as a treatment modality but also as a way of life. All these while walking in the path of Dharma. Hence the motto Shreyam Bharatiyam, Arogyam Ayurvediyam. The founders of this organization started this because we felt the need to spread the knowledge of Bharatiya culture, Ayurveda, the true history of Bharata Rashtra, and values to all of people in every corner of the world. Also, the founders, being Ayurveda aspirants, know the inside out of today's medical field. Hence, they aim to make people aware of this and also try their best to solve this on the go. This is an organization that is created by 28 young, energetic individuals of the 21st century, Gen Z, where all have left behind their differences, insecurities, and have come together united for the betterment of this great nation and its heritage as a whole. We at Panchajanya recognize each and every individual's true potential and make sure they reach their maximum. Everyone who's part of this family performs on their own will, but within the limits of service and contribution. When one becomes part of this organization, he or she will surely feel proud and honored when carrying out the activities. Weaknesses become strength when all are united in the process of progress, in the process of doing good for the society, and that's how the environment is at Panchajanya. No one is considered superior or inferior to any, and all will get a chance to show their interest, love, and devotion towards Bharat and a rich legacy. Our main goal is to reach every individual in creating awareness of our ancient knowledge and wisdom, its efficacy in the modern era, and link with current ongoing affairs, its revival, and most importantly, bringing everyone together in working towards establishing a strong system. In order for all these to be achieved, we have set up various wings with working principles and objectives that help achieve the goals faster and easier in the coming years. They are Ahilya Bhai Wing, Swami Vivekananda Wing, Karnatabala Wing, Govardhana Wing, Ashwin's Wing, Narada Wing, Kautilya Wing, Vedavyasa Wing, Nalanda Wing, and Sanjaya Wing. Coming back to the members involved in our organization, we have doctors, healthcare workers, teachers, students, and people from almost every single occupation available aiming at working together and bringing forward the true essence of Bharat and our traditions. So, all those who fit under these categories are welcomed with honor and privilege. Now, I'd like to introduce to you all today's session, that is today's teacher and the session, that is Vaidya Kavya Mohan, who is leading the topic Prasavottara Vyadhi. And a little brief introduction about her. She is currently working as the assistant professor and pediatric consultant in Department of Kaumara Vritya in Parul Institute of Ayurveda, Vadodara, Gujarat. She has published 6 papers in indexed, peer-reviewed international journals. To add, she has presented 11 papers in different national and international seminars. She had been the resource person for various seminars, conferences, and webinars. She has adjudicated about 4 research papers till date. She is also a reviewer of adjudicated index journals. She has contributed the chapter Biological Effects of Ayurvedic Formulations in the book Ayurveda in the New Millennium, published by CRC Press, Taylor and Francis Group, United States. She authored a textbook on research methodology and medical statistics. She received Best Teacher Award in the year 2023, sponsored by Divya Roshni Foundation, Vadodara, and Kashyapa Award by NEMA. We are honored to have you today here, ma'am. You can start the session, ma'am.
Thank you for the brief introduction. So, I will directly go to the session. Is my screen visible?
Yes, ma'am, it is visible, ma'am. It
Okay,
is
okay.
visible, ma'am, visible.
So, as okay, thank you, thank you. So today, the whole topic is Prasavottara Vyadhi, and in that I am covering one of the topic, that is neonatal jaundice, which is very important. If you are considering it in their exam basis, or if you are considering as a practitioner, both it is important, very important topic, that is neonatal jaundice. So you will be having a brief idea what is neonatal jaundice. So coming to introduction, neonatal jaundice is one of the commonest abnormal physical finding of a neonate during the first week of life, and around two-thirds of all newborns will be suffering from clinical jaundice, or you can tell it as clinical jaundice as physiological jaundice also. So almost all of the newborns will be most of the newborns, more than 80% of the newborns will be suffering from clinical jaundice, or you can term it as physiological jaundice. And coming to preterms and term babies, you know what is preterm baby and what is term baby, so I'm not going into it. Term baby will be having 60% of the term babies will be suffering from neonatal jaundice. And if you are considering preterm babies, around 80% of the preterm babies will be suffering from neonatal jaundice. And the chief characteristic feature of neonatal jaundice is that the yellowish discoloration. And where you can see this yellowish discoloration is over the face, nasolabial folds, and tip of the nose. These are the areas where you can see this yellowish discoloration, which is the characteristic feature of neonatal jaundice. And the neonatal jaundice will be progressing in the area of cephalocaudal progression. Okay, the progression will be in cephalocaudal area, that is from head to toe. Okay, it starts at the face area, and it will be spreading to the, or the appearance you will be seeing over the face, and then it will be seen over the other parts of the body. That is mean by cephalocaudal progression, that is from head to toe. Okay, it never shows first over the soles. It will be always first the yellowish discoloration will be appearing over the face, and at the last you will be seeing the yellowish discoloration over the soles. So that is a general introduction. Commonest physical finding, abnormal physical finding, and in terms, 60% of the terms will be suffering from neonatal jaundice. If you are considering preterm babies, 80% of the preterm babies, main characteristic feature is yellowish discoloration of the skin, and the progression will be in cephalocaudal area. Next, if you are coming to this is not a very advanced or very much generalized definition, but you can consider it as yellowish discoloration of the skin and the mucosa due to accumulation of excess bilirubin in the tissue and plasma in neonates. So, as you know, jaundice is because of the increased level of bilirubin in the blood. Okay, jaundice is happening because of the increased level of bilirubin in blood, and because of this excess bilirubin, what happens is it will show an yellowish tinge over the skin and mucosa. You can see over the mucosal areas also, there will be yellowish discoloration, yellowish tinge will be seen, and this is because of the increased level of bilirubin. So just you can consider it as a definition: yellowish discoloration of the skin and the mucosa due to accumulation of excess of bilirubin in the tissue and plasma in neonates. So that is a brief definition. And this is the bilirubin metabolism. You may be knowing the bilirubin metabolism, but briefly I will explain. I'm not going deep into bilirubin metabolism because it will be already it will be covered in your theory classes or in your physiology classes. So what happens is, once the hemoglobin has broken, it will be converting into heme and globin, or it will be split into heme and globin. So here we are considering only the heme part, globin part is not considered. So the in the first step, the heme will be converted into biliverdin. Okay, In the first step, this heme will be converted into biliverdin, okay, with the help of heme oxygenase enzyme. Okay, heme will be converted into biliverdin with the help of heme oxygenase enzyme, and again this biliverdin is converted into unconjugated bilirubin. So bilirubin is of two types, conjugated and unconjugated. So this heme will be biliverdin will be converted into biliverdin will be converted into unconjugated bilirubin first with the help of the enzyme biliverdin reductase. So this heme oxygenase, biliverdin reductase, all these are enzymes. So unconjugated bilirubin again will be converted into conjugated bilirubin. Okay, this is more softer form or milder form of bilirubin, that is conjugated bilirubin, and it is done with the help of UDPGT. UDPGT is also an enzyme, that is uridine diphosphate glucuronide transferase. UDPGT, uridine diphosphate glucuronide glucorosyl transferate, that is UDPGT. That is also an enzyme which will be converting unconjugated bilirubin to conjugated bilirubin, and again this conjugated bilirubin will be converted to urobilinogen, and it is done by the intestinal bacteria. This happens in the intestine. This urobilinogen splits into two. One will be moving into the one will be moving as uromilinogen, and it will be excreted through the urine, and the other part will be again converted to stercobilinogen, which will be excreted through feces. So this is the normal metabolism of bilirubin. Okay, so heme will be converted into biliverdin first with the help of heme oxygenase. Again, biliverdin to unconjugated bilirubin with the help of biliverdin reductase. Conjugated bilirubin, unconjugated will be converted to conjugated bilirubin with the help of UDPGT, and conjugated bilirubin to urobilinogen with the help of intestinal bacteria, where it will be moving. Some part will be moving to the kidneys, and the other part will be converted to stercobilinogen. Uromilinogen will that goes into the kidneys will be converted as urinary urobilinogen, which will be excreted through urine. Stercobilinogen will be excreted through feces. This stercobilinogen is the thing that gives color to your feces. Okay, so this is the normal metabolism of bilirubin. So next we will see what happens when this bilirubin metabolism, or what is happening for this bilirubin metabolism in neonatal jaundice. Okay, so these are the five factors that affects the bilirubin metabolism in newborns. Okay, as you know, the hemoglobin in fetus or in babies will be fetal hemoglobin. So there is increased hemolysis will be the rate of hemolysis will be increased in newborns. Okay, or what is hemolysis? The breakdown of RBCs. So because of the increased rate of hemolysis, the breakdown of RBCs will be more. Okay, so that is the reason, one of the reason with which the bilirubin level of bilirubin increases. So that is the first reason, increased production of bilirubin. Okay, because of the increased rate of hemolysis in newborns, there will be increased production of bilirubin. Second reason is decreased hepatic uptake of bilirubin. As you have seen in this metabolism, the uptake of the bilirubin by the hepatic system will be decreased. Okay, the amount of bilirubin which the liver takes will be decreased. Next thing is defective bilirubin conjugation. Defective bilirubin conjugation means this stage. Okay, I think you can see my cursor. You can see my cursor, I think. So this thing is this stage is known as conjugation of bilirubin. So what happens is conversion of biliverdin to conjugated bilirubin, either in this stage, either in this stage, the conjugation will be affected either in this stage or in this stage. Okay, mostly this happens, conjugation of bilirubin, this defective bilirubin conjugation. This stage happens here. Unconjugated bilirubin converting into conjugated bilirubin, this stage will be affected, so that the level of unconjugated bilirubin will be increasing. Okay. Next is defective bilirubin excretion. Defective bilirubin excretion is either this stage will be affected, conjugated bilirubin converting into urobilinogen will be affected, or from here the excretion of this bilirubin will be affected. Okay, so that is the stage. Then enhanced enterohepatic circulation. If the enterohepatic circulation is increased, also you will be seeing the rise in bilirubin. So increased prevalence of jaundice among newborn babies. These are the 5 reasons by which you will see increased level of bilirubin or increased cases of jaundice in newborns, increased production of bilirubin, that is commonly because of this hemolysis, increased hepatic uptake of bilirubin. That means that the amount that bilirubin the amount of bilirubin taken by the hepatic system will be less. Defective bilirubin conjugation, the level of or the conjugation of bilirubin by the liver will be defective, or there will be decreased excretion of bilirubin, or the increased enterohepatic circulation. So this this slide is important. These are the factors by which neonatal jaundice happens. Okay, or why the bilirubin metabolism is affected in neonates is by these 5 factors. Next is, as I have told, there are 2 types of bilirubin: unconjugated bilirubin and conjugated bilirubin. So, unconjugated bilirubin is also known as indirect bilirubin, and conjugated bilirubin is known as direct bilirubin. Unconjugated bilirubin will be binding with the albumins, while conjugated bilirubin will be conjugated with glucuronic acid, as I have already told. And unconjugated bilirubin is fat soluble. Okay, unconjugated bilirubin is fat soluble, while conjugated bilirubin is water soluble. Okay, and the other main factor is unconjugated bilirubin can cross the blood brain barrier. As it is fat soluble, it can cross the blood brain barrier and it can attach to the basal ganglia. Okay, and conjugated bilirubin gets excreted with urine and feces. And the last point is unconjugated bilirubin in toxic level, or if it is in high level, it is toxic. Okay, conjugated bilirubin is never toxic. So unconjugated bilirubin is not good. Okay, or unconjugated bilirubin is that which creates further damage in newborns. Okay, or defects in newborns. That is two types of bilirubin, that is conjugated and unconjugated bilirubin. Conjugated bilirubin Conjugated bilirubin is water soluble, unconjugated bilirubin is fat soluble, and the bilirubin that crosses blood brain barrier is unconjugated bilirubin. So this is toxic. Unconjugated is toxic and conjugated is not toxic. And causes of coming to the causes of neonatal jaundice. The first cause is physiological jaundice, or this is also a type of jaundice. Immaturity. As you know, newborns are immature. All their organs or organ systems are not mature like an adult. So maturity is also a problem. The next major reason or the common cause of neonatal jaundice is hemolytic diseases of newborns. Okay, or in short form, it is known as HDN, hemolytic diseases of newborn. Okay, it, in hemolytic diseases, this RH and ABO incompatibility is coming. Okay, RH and ABO incompatibility, you may be knowing what is RH incompatibility and what is ABO incompatibility. RH factors include positive, see if o positive or negative. Okay, that is RH factors. Positive and negative is considered as RH factors. ABO incompatibility, uh, all these will be covered in your physiology classes. So if I'm going deep into it, again the class will be very long, so I'm not going deep into it. So RH and ABO incompatibility are included in hemolytic diseases of newborns, infections both intrauterine and postnatal. Okay, mainly the causes intrauterine infections. Intrauterine infections include this toxoplasmosis, torch infections, toxoplasmosis, rubella virus. All these are included under intrauterine infections. And postnatal is in any infections that is happening to the baby after delivery. Like you can consider sepsis. Okay, sepsis, neonatal sepsis is one of the major cause of neonatal jaundice. Then G6PD deficiency. G6PD deficiency is also a genetic disorder where there will be hemolytic anemia. Okay, where there is hemolytic anemia. Hemolytic anemia causes increased rate of hemolysis. So breakdown of RBCs will be more in G6PD deficiency, which causes jaundice. Then subcutaneous bruising. If there is any bruising, the small type of bruising won't be affecting, but if the bruises are very large, it can be a reason for neonatal jaundice. And cephalohematoma and caput succedaneum, you might be knowing what is cephalohematoma and what is caput succedaneum. In cephalohematoma, the cases which are having cephalohematoma may suffer with neonatal jaundice, because for coping up with the cephalohematoma, there will be more production of RBCs. As the production of RBCs increases, there will be more breakdown of RBCs, leading to increased amount of bilirubin. So the same thing is happening in subcutaneous bruising also. For coping up with the situation, the production of RBCs will be more, and as the production of RBCs increases, the breakdown of RBCs also increases, which causes increased amount of bilirubin. Same mechanism is happening in subcutaneous bruising and cephalohematoma. And some of the drugs, for example, vitamin K. Vitamin K, if the administration, you will be giving vitamin K as a stat dose to a newborn for preventing hemorrhagic diseases. Okay, for preventing hemorrhagic diseases, you will be giving vitamin K to a newborn as a stat dose. So if the dose of vitamin K is more, even that can lead to neonatal jaundice. And salicylates, when administered to the mother, or maybe if oxytocin, if the amount of or the dose of oxytocin is more, that can also cause neonatal jaundice. And the other reason is breast milk jaundice. Breast milk jaundice I will be covering later. So these are the causes. So the very common cause of jaundice is hemolytic diseases. Okay, that is RH and ABO incompatibility. Cephalohematoma. Cephalohematoma is also a common cause. Okay, then breast milk jaundice, that is also a common cause. G6PD deficiency, it is a genetic disorder, though it is not much common, but still that is considered a very valid cause. Then immaturity. Okay, physiological jaundice I will be explaining later. And according to, if when you are considering the same causes, we are dividing it into age. Okay, we are dividing the same causes according to the age. If the jaundice is appearing within 24 hours of birth, okay, the causes will be hemolytic diseases of newborn, infections like I have already taught, torch infections, bacterial infections. Bacterial infections include the neonatal sepsis. Okay, neonatal sepsis is a bacterial infection, G6PD deficiency, and these drugs. Okay, so if the jaundice occurs within 24 hours, then these will be the major reasons, or these are considered as the common reasons if the jaundice appears within 24 hours. Okay, if the jaundice is appearing between 24 to 72 hours, then it is physiological jaundice. Okay, physiological jaundice, it is aggravated and prolonged by immaturity, birth asphyxia, hypothermia, hypoglycemia, drugs, cephalohematoma, breastfeeding, infections, hemolytic diseases. Okay, so keep in mind that if the jaundice is occurring within 24 and 72 hours, then that is physiological jaundice. Then according to after 72 hours and within first 2 weeks. Okay, if the jaundice occurs after 72 hours and within first 2 weeks, then the reason will be, cause will be septicemia, neonatal hepatitis, breast milk jaundice, and metabolic diseases. Okay, so these are the causes. See, just for your understanding, I have kept it according to age. Okay, it is not needed that you should explain the causes according to age. For your understanding or for easy learning, I have kept this like according to age, so it will be easy for remembering. Okay, so if you want, you can by heart the causes like this. Okay, or if it is some, so for some students it will be easy to learn the causes if we are dividing the causes accordingly. That's why I have kept the slide. So this is first is according to 24, within 24 hours, next is between 24 and 48 72 hours, this is after 72 hours. Okay, it is not mandatory that you should write like this. You can write even generally, you can mention the causes. And again for easy understanding, again I have divided the causes into two, that is hemolytic diseases and non hemolytic causes and non hemolytic causes. Already I have told, under hemolytic causes, RH incompatibility, ABO incompatibility, G6PD deficiency, thalassemia, and hereditary spherocytosis. Okay, non hemolytic causes, prematurity, extravasated blood, inadequate feeding, polycythemia, breast milk jaundice, septicemia, intrauterine infections. Already I have told all these things. Just for whichever students want to learn it in different aspects, you can learn it like this. Okay, then so there are mainly two types of jaundice, that is physiological jaundice and pathological jaundice. Okay, so physiological jaundice is always, the physiological jaundice appears after 24 hours. Okay, physiological jaundice or clinical jaundice always happens or always appears after 24 hours, and pathological jaundice will be seen before 24 hours. Okay, if the baby is if you see the yellowish discoloration of, or if you see the raised serum bilirubin level before 24 hours, then it is pathological, and if it is after 24 hours of birth, then it is physiological jaundice. So again, physiological jaundice, difference of appearance will be seen in term babies and preterm babies. In term babies, 60% of the term babies will be affected with physiological jaundice, and when you are considering preterm babies, 80% of the preterm babies will be suffering from physiological jaundice. And the time of appearance of physiological jaundice in term babies is between 36 to 72 hours. Okay, in term babies, the time of appearance of physiological jaundice is 36 to 72 hours, or it can be even from 32 hours also. You can see the yellowish discoloration. Maximum intensity will be seen on the fourth or fifth day, or maximum intensity or maximum level of bilirubin will be seen during fourth or fifth day, and the serum bilirubin will be increased or it will be raised, but never more than 15 mg per dl. Okay, it will be always less than 15 mg per dl. Disappearance, day of disappearance is 10th day. It is self limiting. Usually it doesn't need any kind of intervention like phototherapy or anything. It doesn't need anything. It is self limiting. It will be in term babies, it will disappear by the 10th day. Okay, and there is no special clinical feature, or there is no special feature with which you can diagnose physiological jaundice. Only thing is, there will be yellowish discoloration, and the diagnosis is made by the time of onset. Okay, if the time of onset is after 36 hours or 32 hours, then it is considered as physiological jaundice. Then maximum limit of intensity is serum bilirubin will be always less than 15 mg per dl. So if the serum bilirubin level is 12 mg per dl or 13 mg per dl, by the fourth or fifth day, then it is considered as physiological jaundice and age of disappearance. It will be disappearing by 10th day. Okay, so that is physiological jaundice in term babies. And when coming to preterm babies, 80% of the preterm babies will be suffering from physiological jaundice. Same as, almost it is same as term babies, but as preterm babies are more immature, okay, in some preterm babies it may be appearing earlier than preterm term babies. Okay, as preterm babies are more immature, physiological jaundice will be appearing earlier than, maybe sometimes it may appear earlier than term babies, but it will never appear before 24 hours. Okay, always, if it is a term baby or if it is a preterm baby, physiological jaundice will be seen only after 24 hours. Okay, and in preterm babies, the maximum intensity you will see during 6th or 7th day, and serum bilirubin can reach up to 15 mg per dl. It never crosses 15 mg per dl in preterm babies. Okay, if it is 16 mg per dl, even you can consider, but it will never cross, maximum it will be appearing up to 16 or 17 mg per dl. So and it disappears by 14 days. Okay, by the 14th day, in preterm babies, physiological jaundice will disappear. Okay, so that is the difference of appearance in physiological jaundice in term and preterm babies. In term babies, appears between 36 to 72 hours. Maximum intensity will be attained by fourth or fifth day. And serum bilirubin will be less than 15 mg per dl, and it disappears by 10th day. In preterm babies, it will be appearance will be same like that of term babies, but may appear little earlier, but never before 24 hours. Maximum intensity will be seen during 6th or 7th day, and serum bilirubin reaches up to 15 mg per dl, and the day of disappearance is by 14th day. Okay. Then coming to pathological jaundice, 5% of newborns, 5% of newborns develop pathological jaundice. Pathological jaundice is very rare. Okay, so 5% of the newborns will be developing pathological jaundice, and pathological jaundice will be seen within 24 hours, or pathological jaundice always appears before 24 hours. It is also known as unconjugated hyperbilirubinemia. Okay, unconjugated hyperbilirubinemia. As I have told already, unconjugated bilirubin is a toxic form. Okay, unconjugated bilirubin in high levels, it can cross the blood brain barrier. So pathological jaundice should be, if the baby is having pathological jaundice, you should be very cautious. Okay, so that is the difference between, the major difference between physiological and pathological jaundice is, physiological jaundice always appears after 24 hours, and pathological jaundice always appears before or within 24 hours. This should be the very first point, or the very major difference between pathological and physiological jaundice. Okay, and there is one more type that is known as exaggerated physiological jaundice. This is also a form of physiological jaundice only, but it is called as exaggerated physiological jaundice in some conditions. Okay, in some conditions, there is chance that the physiological jaundice may prolong, okay, or maybe getting exaggerated, so that you should go for intervention, okay, like phototherapy or exchange blood transfusion. In some cases, only in very rare cases, the physiological jaundice may be prolonged or exaggerated. So some of the conditions include, if the mother was diabetic, okay, if the mother was diabetic, or IVH, if the baby is having IVH, intraventricular hemorrhage, cephalohematoma, hypothyroidism, breast milk inhibitors or breast milk jaundice, hypoxia, CHD, that is congenital heart diseases, delayed passage of meconium, congenital infections, polycythemia, and certain drugs. Okay, in these conditions, there is chance that the physiological jaundice may prolong. or may get exaggerated. That means the serum bilirubin level may exceed the usual level, okay, or the usual limit, okay. So in such cases, it is known as exaggerated physiological jaundice, or it is considered, or it is also known as hyperbilirubinemia. Don't get confused with hyperbilirubinemia and unconjugated hyperbilirubinemia. Unconjugated hyperbilirubinemia depicts pathological jaundice. Hyperbilirubinemia is considered as physiological jaundice only. Pathological jaundice is especially known as unconjugated bilirubinemia, because here there the unconjugated bilirubin level will be increased. Okay. So I think up to this part it is clear. Okay. Then coming to complications. So these are the, so I have explained the types: pathological, physiological. Then one more type, that is exaggerated. It is a subtype of physiological jaundice, that is exaggerated physiological jaundice. Then causes of jaundice: neonatal jaundice, and bilirubin metabolism, normal bilirubin metabolism, and what happens to the bilirubin metabolism in neonatal jaundice. Okay. Now coming to complications, which is also very important. If it is asked for an as an essay question, you have to mention the complication. So the commonest complication of neonatal jaundice is kernicterus. Okay, you might have heard the term kernicterus. So this is a complication of neonatal jaundice, kernicterus. It is a very rare but a very serious complication. Okay, very rare and a very serious complication of neonatal jaundice, which will be affecting the whole life of a baby. Okay, the damage is lifelong, or the damage is permanent. And high levels of unconjugated bilirubin, I have already told, unconjugated bilirubin is very toxic, and as it can cross the blood brain barrier. Okay, what happens is, the unconjugated bilirubin, it is fat soluble. As it is fat soluble, it will be, once it crosses the blood brain barrier, it will be attaching to the basal ganglia. Okay, so once it get attached to the basal ganglia, slowly it will be creating damage to the brain. Okay, so high levels of unconjugated bilirubin cross the blood brain barrier and it accumulates in the brain. Then the what will be the future, what will be the future of kernicterus is, it causes a permanent brain damage. So the damage that is caused by the kernicterus or unconjugated bilirubin is never reversible. It is permanent, leading to development delays. The child may have developmental delay. Cerebral palsy, one of the cause for cerebral palsy, it is kernicterus. Hearing loss, if it is affecting the auditory area, it can cause hearing loss and other neurological impairments. Okay, so as you will be knowing that there are different areas of the brain, depends upon which area the unconjugated bilirubin is accumulating, depends upon that area, there will be the neurological impairments. Okay, and usually because of kernicterus, or means the baby will be suffering from cerebral palsy and developmental delays. Okay, so this is a common complication, means common means very important complication or very serious complication of neonatal joint. It is not a common complication. Common complication, with the term, what I mean is, it is a very serious complication. Okay, very serious complication of neonatal jaundice. Kernicterus, don't forget the term kernicterus. Next is acute bilirubin encephalopathy. Acute bilirubin encephalopathy is also affecting the brain. Okay, newborn with severe jaundice causes acute bilirubin encephalopathy, but here the defect or the damage that is happened to the brain is reversible. Okay, the damage that happened to the brain is reversible, and it causes, how you can diagnose this, it causes lethargy. The baby will be feeding will be very poor, or the baby will not be taking the feeds properly. There will be irritating high pitched cry and abnormal muscle tone. Okay, Severe form of encephalopathy can lead to kernicterus. Again, the severe form of, if the encephalopathy is becoming severe, it can lead to kernicterus. Okay. uh, in detail is not required for, as of UG basis, in detail is not required. Just keep in mind that there are two complicate, not only two, there are other complications also, but very important complication is, one is kernicterus. Kernicterus is very important, even important than acute bilirubin encephalopathy. So this kernicterus should be there in your exam paper. And the other complication is acute bilirubin encephalopathy. The difference is, in acute bilirubin encephalopathy, the brain damage is reversible, but in kernicterus, the brain damage is irreversible. Lifelong, the baby will be having the damage. Okay. Then diagnosis. Diagnosis is very simple. You have to take the total serum bilirubin level in the baby, with which you can diagnose the type of jaundice and the effect of jaundice. Then the other one is clinical examination. Okay, intensity of yellow staining of skin and its cephalocaudal progression. Okay, intensity. Clinical assessment by looking at the skin. There is a special rule by which you can uh, diagnose the level of bilirubin or the neonatal jaundice. What will be the level of neonatal bilirubin in neonatal jaundice? There is a special rule with which you can diagnose it, that I will be showing you later. Okay, so that is with clinical assessment and with total serum bilirubin level, you can diagnose neonatal jaundice. And in most cases, or if it is a physiological jaundice, in most of the cases, it does not require any kind of investigations. By looking the case itself, by the clinical examination itself, you will understand that, or by asking the history, when the yellowish discoloration had first appeared, all those reasons. By asking all those reasons, or if there is any drug administered to the mother, by asking all such questions, you can diagnose that the baby is having physiological jaundice. And so not all the cases of physiological jaundice require investigation, but if the baby is considered as a high risk case, then investigation is required. High risk cases include history of severe jaundice or exchange blood transfusion or kernicterus in previous sibling. If the previous baby, if it is a multi, and if the previous baby was having history of severe jaundice or exchange blood transfusion or history of kernicterus, then this baby should be, or this baby should be investigated, or blood checkup should be done. If the blood group of the mother is O group, or if the blood group of the mother is Rh negative. Okay, usually ABO incompatibility, O group is affected. So if the mother is having O blood group, or if the mother is having Rh negative blood group, then investigation is mandatory. Then if the onset of jaundice is within 24 hours or after 72 hours, okay, even after the baby is having jaundice after 72 hours also, it is also, you have to take it seriously. So if it is within 24 hours and after 72 hours, then within 24 hours is pathological, and after 72 hours there will be some other reason. Okay, so in such cases also you should go for investigation. Sick jaundiced baby. Sick jaundiced baby means, if the baby is having, even though if the baby is having physiological jaundice, but if the baby looks sick, if the sick means if there is poor feeding, if there is a high pitched cry, or if the baby is not active, in such cases also, that is considered as a sick jaundiced baby. Okay, in such cases also investigations should be done. Then if there is persistence of jaundice beyond 3 weeks, that is, if the physiological jaundice is exaggerated or prolonged, then also you have to go for investigation. Jaundice infant with yellow colored urine or clay colored stool. If you are seeing too much yellow colored urine, or if the stool is clay colored, then also you have to go for investigation. So these are considered as high risk cases. In high risk cases, if the baby is coming under any of the given criteria, then you have to go for investigation. Okay, And if the baby is not coming under any of these criteria, and if it is a physiological jaundice, then there is no need of again and again there is no need of investigations. If you want, for the concern of the parents, you can check the bilirubin level again and again every 24 hours or every 72 hours. There is no need to check the bilirubin level. You can check it for one time, and you can, if required, you can do intervention like phototherapy, or else there, even in physiological jaundice, the intervention is not required. It is self-limiting. By the normal day of disappearance, it will be disappearing. Okay. And this is known as Kramer's rule, okay, or Kramer's modified Kramer's scale. This is the scale by which you can assess the neonatal jaundice clinically. Okay, by the clinical assessment, clinically you can assess neonatal jaundice or the level of bilirubin with modified Kramer's rule. Okay, so there are 5 zones. You can see here there are 5 zones. Zone 1 is face area. Zone 2 is chest and upper abdomen. Zone 3 is lower abdomen and thighs. Zone 5 is soles and palms. Okay. So if the yellowish discoloration is seen over the zone 1, if the yellowish discoloration is seen only over zone 1, that is face, then the level of bilirubin is considered as 4 to 6 mg per dl. Okay, 4 to 6 mg per dl. If the yellowish discoloration is seen over the zone 2 area, then then the level of bilirubin will be considered as 8 to 10 mg per dl. If the yellowish discoloration is over zone 3, then it is 12 to 14 mg per dl. Okay. If it is in zone 4, yellowish discoloration is over the zone 4, then the bilirubin should be considered as 15 to 18 mg per dl. And if the yellowish discoloration is over the zone 5 areas, then the bilirubin level should be considered as 15 to 20 mg per dl. Okay, so this is known as Kramer's rule. How you should check this? Okay, I have checked for the video. I got a video also, but I was not able to play it over the PowerPoint. That's why I didn't include the video. After this class, just go and check in YouTube. You will be getting videos of how to check the Kramer's rule. Just go and check it so that you can do the clinical assessments uh, during your practical exams. Okay, so I will just explain how to do Kramer's rule. You should make the baby lie down, okay, and just press over the zonal areas. Okay, just press over the zones. If it is over the face, you can press over the forehead. You can press over at the middle of the forehead. Press for 2 seconds and release. Okay, press for 2 seconds and release. Once you are pressing and releasing, there will be an area of blanching. Okay, there will be an area of see, if you are pressing and releasing your finger, you will be seeing a area where there will be blanching means there will be light, or the area looks pale. Okay, so that blanched area will be appearing yellow. Okay, in a newborn, the blanched area will be area of blanching. That area will be having yellowish discoloration. Okay, so how, again, once again I will tell, you have to just press and release. Check over the, if possible, check over the bony areas. That is, over the face you can check over the forehead. Okay, once pressing and releasing, you will see an area of blanching. That area will be having yellowish discoloration. This is how you have to check the Kramer's rule. So there are 5 zones. If the yellowish discoloration is over the face, then consider bilirubin level as 4 to 6 mg per dl. Chest and upper abdomen 8 to 10 mg per dl. Lower abdomen and thighs 12 to 14 mg per dl. Arms and lower legs 15 to 18 mg per dl. Palms and soles 15 to 20 mg per dl. Then management. Coming to management, there is only, the management is, you are having only 2 methods. Okay, 2 methods of treatment. One is phototherapy and the other one is exchange blood transfusion. Okay, So phototherapy, this slide later I will be coming to this slide. Phototherapy, it is one of the very effective method in for neonatal jaundice. That is, what you are doing is you are exposing the newborn to either blue lights or white lights. Okay, you are exposing the baby to blue lights or white lights. What this light does is, the light will be breaking down the unconjugated bilirubin into a water soluble form. Okay, which can be easily excreted through the liver. Okay, which can be easily excreted by the liver. And two types of phototherapy units are there. One is conventional phototherapy and the other one is fiber optic phototherapy. Pictures I will show you later. So these are the two methods, conventional and fiber optic phototherapy. And the nanometer, how much nanometer you can use, how much nanometer of light you can use is 425 to 475 nanometer you can use, because the bilirubin is able to absorb 425 to 475 nanometer maximum. Okay, so this is one of the safest and effective method for reducing bilirubin levels in babies. And what happens is, the process is known as photoisomerization, where the unconjugated bilirubin will be converted into a water more stable and water soluble form, which can be easily excreted by the liver. Okay, so this process is known as photoisomerization, and the stable water soluble form is known as lumebilirubin. Okay, so this lumebilirubin can be easily excreted through the feces and through the bile. Okay, easily excreted through bile, feces, and to a lesser extent through urine, without any need for conjugation in the liver. Because in the factors affecting the bilirubin metabolism, I have told that there is defective conjugation mechanism. So once we are using phototherapy, there is no need for the liver to conjugate the bilirubin. Okay, so directly it once it is converted to for with photoisomerization, once it is converted to lumebilirubin, can be easily excreted through bile, feces, and to an extent through urine. So that is the process happening. Just remember, it is a very safe and effective method. The newborns will be exposed to white or blue lights. What happens is, the process is photoisomerization. In photoisomerization, what happens is, the unconjugated bilirubin will be converted into more stable water soluble form, that is known as lumebilirubin, which can be easily excreted through bile, feces, and to some extent through urine also. There are two main types of phototherapy, that is conventional phototherapy form and fiber optic form. And also the bilirubin can absorb 425 to 475 nanometer of light maximum. See, these are the two methods. This picture shows the conventional form of phototherapy, which will be available in most of the for most of the NICUs, and this is known as fiber optic form. In fiber optic form, what they are doing is, this is a blanket. Okay, this is a blanket which will be having the blue lights, and what you have to do is, you have to keep the blanket covering the baby. Okay, you have to keep the blanket covering the baby, which will be more effective, because in this form what happens is, you have to take the baby for feeding, you have to disturb this process. Okay, once you have keeping the baby in phototherapy, in between you should be giving the baby for feeding. Okay, otherwise there will be chances of dehydration. So you have to discontinue phototherapy and you have to give the baby for feeding. In this fiber optic form, with the blanket only you can give the baby for feeding, and there is less side effect in fiber optic form. And when to start phototherapy? So when you are considering this, hyperbilirubinemia in a healthy term baby. Okay, management of hyperbilirubinemia in healthy term baby. So first column is of age, that is if the age is less than 24 hours. Okay, if the age is less than 24 hours, there is rare chance that the baby will get physiological pathological jaundice. So if there is a visible icterus happening, okay, if you can see icterus visibly, then you have to go for investigation. If the age of the baby is within 25 and 48 hours, you have to consider doing phototherapy if the level of bilirubin is more than or equal to 12 mg per dl, and you have to keep the, if the level of bilirubin is more than 12 mg per dl, then just you consider, means you have to keep in mind that the baby, sometimes the baby may require phototherapy. But if the level of bilirubin is more than 15 mg per dl, then you should keep the baby in phototherapy. And if the level of bilirubin is more than 20 mg per dl, then exchange blood transfusion is required. Okay, if the age of the baby is, I know this is little bit confusing. You won't understand it at a stretch. Just save the slide, okay, and just hear the explanations. By hearing the explanation one or two times, you will get to know. Okay, so if the age of the baby is within 49 and to 72 hours, you should consider doing phototherapy. So the age of the baby is increasing here. Okay, now the baby has crossed the 48 hours. Now the baby is 49 to 72 hours, means the baby has crossed almost 2 days. Okay, so the baby is in third day now. So you have to consider phototherapy if the bilirubin level is more than or equal to 15 mg per dl, and you should keep the baby in phototherapy if the bilirubin level is more than or equal to 18 mg per dl, and if the bilirubin level is more than 25 mg per dl, then you should go for exchange blood transfusion, because the bilirubin is not going to come down with phototherapy. Okay, so you have to go for exchange blood transfusion. And if the age of the baby is more than 72 hours, then consider phototherapy if the bilirubin level is more than 17 mg per dl. Then you should keep the baby in phototherapy if the bilirubin level is more than 20 mg per dl, and exchange blood transfusion should be considered if the bilirubin level is more than 25 mg per dl. Okay, this is still confusing. I know many of you might not have understood this, but save the slide and hear the explanations repeatedly so that you can understand the slide. Okay, and the other, keep in mind that exchange blood transfusion should be considered only if the phototherapy is failing. Okay, if the phototherapy fails to reduce the bilirubin levels, then only you have to go for exchange blood transfusion. Otherwise exchange blood transfusion is not required. This is another indication for phototherapy and exchange blood transfusion. Yeah, you can skip this slide because again so much values you have to by heart. So instead of this, you can by heart this slide or this table. Okay, this is again bit confusing, so I'm not going to explain this because again it will be confusing for you. So I'm skipping the slide, and this I have already told. First one is conventional method and second one is fiber optic method. Then how to do procedure of doing phototherapy. It should be extra light sources should not be there. Only blue lights should be there. White slings or curtains on either sides of the infant. The infant should be completely in a closed setup. All the clothes should be removed except the diaper. The diaper or the genital area should be covered. Okay, especially in male babies, male infant genital should be covered, because as you know that the scrotum or the testis is inside the scrotum, so that the genital area will be affected in future. So not only in male babies, but special care should be taken in case of male babies. The genital area should be covered in both male and female babies, and the light source should be kept at a distance of about 35 centimeter from skin. Okay, light source or the blue light should be kept about 35 centimeter away from the skin. And if you are doing intensive phototherapy, okay, intensive phototherapy means the level of the phototherapy uh, or you are doing very if the bilirubin level is too high, okay, you should be doing intensive phototherapy, or the rate of doing phototherapy should be more. In such cases, you can reduce the distance to 15 to 20 centimeter. Okay, or if you are now doing normal phototherapy, the distance should be 35 centimeter away from screen, away from skin. If you are doing intensive phototherapy, then you can reduce the distance to 15 to 20 centimeter. Other thing is, the eyes of the baby should be covered. As you might have seen in the picture, here also the eyes of the baby is covered. In this also the eyes is covered. Why? Because it can cause, these lights can cause retinal damage. Okay, and the position of the baby should be changed on and off, because if the light is covering, because if the baby is kept only in one position, only though that area will be covered. Okay, bilirubin will be distributed to the whole body. If you are keeping a single surface, the baby only that surface will be covered. For covering maximum surface area, you should change the positions. Okay, and intensive phototherapy, if you are doing intensive phototherapy, it will reduce the serum bilirubin level up to 1 to 2 mg per dl within 4 to 6 hours. If you are doing intensive phototherapy for 4 to 6 hours, then it will be reducing the total serum bilirubin level up to 1 to 2 mg per dl in every 4 to 6 hours. Okay, so that is the procedure of doing phototherapy, and these are different types. First one is LED phototherapy unit, second one is compact for fluorescent tubes, and the third one is halogen tubes. Usually this is available for the first one will be available in nowadays. This first one is preferable. Okay, then monitoring and stopping of phototherapy. What all things to be monitored, and when you have to stop phototherapy. Temperature should be monitored, because as you have seen here, this is an open care system. Okay, in the warmer, the baby will be in an open care system, so that there is chance of hypothermia, and as you are keeping warmer also, there is chance of hyperthermia also. So for avoiding that, the temperature should be monitored, and to know the levels of bilirubin, uh, total serum bilirubin level should be measured every 12 to 24 hours. Also references of 6 to 8 hours monitoring of serum bilirubin. Then stop phototherapy when the total serum bilirubin level falls to 13 to 14 mg per dl. So up to 15 mg per dl is okay. So if the serum bilirubin level is dropping to 13 to 14 mg per dl, then you can stop phototherapy, and there is chance of rebound in total serum. Once you stop the phototherapy, then there is chance that the serum bilirubin level again increases. So for that, you have to monitor the serum bilirubin level during next once after stopping phototherapy for the next 6 to 12 hours. Again, you have to check the total serum bilirubin level. Side effects. Side effects of phototherapy include passing of loose green stools. This is because of the high content of photo degeneration products of content of products in phototherapy. Okay, passage of loose green stools, and there is chance of dehydration. Less com Though dehydration is less common, there is chance. So that what you have to do is, you have to give additional 20 to 40 ml per kg per 24 hours feed. Okay, additionally than the normal, additionally 20 to 40 ml per kg per 24 hours feed should be given if the baby is in phototherapy. And there is chance of hyperthermia, irritability and dehydration due to water loss. Then bronzing of skin, urine, and serum. That is known as bronze baby syndrome. Okay, bronzing of skin, urine, and serum. It is self-limiting. This is also due to the photo degeneration products, or because of the blue lights. And the delayed complications include retinal damage and skin malignancy. This is again the bronze baby discoloration or bronze baby syndrome. So these are the side effects. The common side effects include loose green stools, hyperthermia, bronze baby syndrome. These are the common complications. Delayed complications include retinal damage. Then the next management type is exchange blood transfusion. It should be performed if the total serum bilirubin level reaches the age specific cutoff. Okay, if the total serum bilirubin level is reaching to the age specific cutoff, then only you have to do exchange blood transfusion, or if the baby is showing signs of bilirubin encephalopathy irrespective of total serum bilirubin levels. If that sometimes even before checking phototherapy, sorry, before checking total serum bilirubin level, if the baby is showing signs of bilirubin encephalopathy, then also you can go for exchange blood transfusion. And indications of ET in infants with the Rh hemolytic diseases. Rh hemolytic diseases include if the cord bilirubin level is of 5 mg per dl or more. Okay, if the cord bilirubin, that is cord bilirubin means blood taken from the cord. Okay, cord bilirubin of 5 mg per dl or more, or if the cord hemoglobin is less than 10 gram per dl, or hematocrit is less than 30 percentage, or if the unconjugated serum bilirubin of 10 mg per dl within 24 hours or 15 mg per dl within 48 hours is present. Okay, unconjugated serum bilirubin, if the serum bilirubin level, unconjugated serum bilirubin is 10 mg per dl within 24 hours or 15 mg per dl within 48 hours of birth. Okay, these are the indications. This you should by heart. Indications of ET in a hemolytic diseased baby: cord bilirubin of 5 mg per dl or more, cord hemoglobin less than 10 gram per dl, and unconjugated serum bilirubin of 10 mg per dl within 24 hours or 15 mg per dl within 48 hours. Okay, so this is phototherapy and exchange blood transfusion. And you should know even breast milk jaundice. What is the difference between breast milk jaundice and breastfeeding jaundice? So uh, breast milk jaundice is happening, or the cause of breast milk jaundice is exact cause is unknown, but it is believed that certain substances or some substances which is present in the breast milk may inhibit the ability of the baby's infant to process the bilirubin, or the conjugation of the bilirubin will be affected because of some substances in the breast milk. Okay, so because of which there will be inhibition of conjugation of bilirubin, which can increase the level of bilirubin in baby's blood. Okay, okay, this will be most often occurs towards the end of first week of life. Okay, usually breast milk jaundice is seen during the end of first week of life and can continue till several weeks. It can continue till 1 month also, but the condition is no treatment is required, and the condition is self-limiting. No treatment is required unless the bilirubin level is too high. Otherwise, there is no need of any treatment, and there is no need of stopping the breastfeeding also. But if the mother is too much concerned, or if the mother is too much worried, you can stop the breastfeeding. Otherwise, there is no need of stopping the breastfeeding also. Within some expected time, the bilirubin level will be coming down. And breastfeeding jaundice happens because the baby may not be getting the required amount of milk. Okay, the baby may not be getting required amount of milk. What happens is, because of which there will be elevated bilirubin levels. Okay, elevated bilirubin levels due to increased reabsorption in bilirubin. Okay, at the intestine level, if the baby is not getting required amount of breast milk, what happens is at the intestine level there will be reabsorption of bilirubin, which increases the level of bilirubin. And the other possibility is, as the baby is not getting enough breast milk, the passage of meconium will be delayed. Okay, there will be delay in the passage of meconium. So when the meconium is not passing properly, or when the baby is not passing stools, what happens is again the stercobilinogen will be remaining in the stools, and there will be reabsorption. Again, it will be reabsorbed in the circulation, which will be causing increase in bilirubin. So that is breast milk jaundice and breastfeeding jaundice. So breast milk jaundice, both the conditions are self-limiting. Okay, both the conditions are self-limiting. So breast milk jaundice is maybe because of some of the substances present in the breast milk which will be inhibiting the conjugation of bilirubin, and it is a self-limiting condition. There is no need for stopping the breastfeeding. You can continue the breastfeeding. Sometimes it will be coming down within a week, or sometimes it can prolong for more than 2 or 3 weeks, but it is still self-limiting. No intervention is required, no phototherapy or no exchange blood transfusion is required. And breastfeeding jaundice happens because of inadequate breast milk, or inadequate breastfeeding, okay, because of which there will be reabsorption of bilirubin from the intestine. So when the baby is not taking proper feeding, or when the feeding is inadequate, there will be less passage of meconium or less passage of the stools. So that as the stools are as there is less passage of stools, again there will be reabsorption of bilirubin into the circulation. So, for in case of breastfeeding jaundice, you have to more feeding should be given so that you can reduce the risk of jaundice. Okay, so that is the difference between breast milk and breastfeeding jaundice. Uh, thank you for patient listening. I know that this is a little big topic, but still this is very important. Okay, one again I will tell the things that should be remembered. You should remember the cause, bilirubin metabolism, factors affecting bilirubin metabolism in neonatal jaundice, causes of jaundice. If you want, you can remember according to age, according to etiology. Then types of jaundice, physiological jaundice and pathological jaundice. This is a subtype of physiological jaundice, and the causes, not the causes, like maximum intensity, day of disappearance, serum bilirubin level, all these things. Then complication, at least you should remember chronic stress, because which is this is a very serious complication, acute bilirubin encephalopathy. Diagnosis, how you have to diagnose with total serum bilirubin level, how you can diagnose with clinical assessment, which are the high risk cases. Kramer's rule is the rule that with which you can identify neonatal jaundice clinically. Management, phototherapy, and exchange blood transfusion. This table should be more clear for you. Then phototherapy, what is happening in phototherapy? Photoisomerization. When you have to start the phototherapy, when you have to start the phototherapy, you can use this table. When you have to start phototherapy, then procedure, what are the procedures to be followed during phototherapy? Monitoring, how to monitor, what to monitor, and when to stop the phototherapy. What are the side effects of phototherapy? Exchange blood transfusion, when you have to do exchange blood transfusion. Then, what is breast milk and what is breastfeeding jaundice? This can be asked as a Viva question also, and it can be asked for even 2 mark or 5 mark question. Difference between breastfeeding and breast milk jaundice. And phototherapy, please try to learn all these points, because if the phototherapy is asked for your practical exams also, you can write this phototherapy. What is happening in phototherapy? When to start? Procedure and stopping of phototherapy and side effects. Okay, so thank you for your patient listening. The topic was big. I took almost, now it is almost 10 o'clock. I took little bit more time, but as the topic is too too much, I should cover at least these points, so that the students will be, especially for UG students, they will be very new to these topics. So pardon me if I have taken more time. Thank you so much.
Ma'am, thank you so much, ma'am. No, ma'am, you didn't take any extra time. This information needed as has to be conveyed, and we thank you a lot for giving your valuable time and accepting our invitation to do this session. I hope this session has helped a lot of students and given them a lot of tips on how to prepare in this topic and all the important points which you have covered in this topic. And we would like to collaborate with you more in the future. And we thank you a lot from the team of Panchajanya. And if anybody is having any doubts, we'll be sharing the doubts to ma'am, and ma'am will be replying and will be forwarding them back to you. And from the team of Panchajanya, we thank you so much, ma'am, for accepting our invitation and making a successful session. Thank you, ma'am.
Thank you so much. Thank you for giving me the session. Maybe next tomorrow, next topic from Prasavottara Vyadhi will be covered. That is neonatal sepsis. So again, that is a even big topic. Okay, so it may also take a little bit more time than required. So thank you for everybody's patient listening. If you have any doubts, you can just forward the messages to me so that I can clear the doubts.
Sure, ma'am. We'll forward any doubts to you, ma'am. Thank you so much,
Okay.
ma'am.
Thank you. Thank you. Thank you.
Thank you.
Shall I leave the session?
Yes, ma'am. Yes, ma'am.
Okay. Thank you so much.
Thank you.